Good morning, everyone, and thank you for joining us. Today's webinar, entitled Antimicrobial Stewardship in Long-Term Care, The Time Has Come, The Critical Role of the Consultant Pharmacist, is brought to you in partnership with the Massachusetts Department of Public Health and Tufts Medical Center. My name is Nayara de Oliveira with the New England QIN-QIO, and before we begin today's program, I have a few housekeeping items to review. This webinar will be recorded, and the presentation will be available within a few business days on the event webpage. After these announcements, I will be muting all lines for the duration of the presentation, but we ask that you please do not put your line on hold. Also, you may manually mute your line by pressing *6 or using your manual mute button. If you have a question at any point throughout the presentation, please enter it to the chat panel to the right of your screen. Please make sure to send your comments to all participants. A lazy Victor from the QIN-QIO team in Massachusetts will be monitoring and responding to your questions and comments in real time. We will also have time for questions over the phone at the end of the presentation. It is important to note that today's speakers have no relevant conflicts of interest to disclose, and this webinar has been granted ACPE credit by the Connecticut Pharmacists Association for 1 contract hour. Pharmacists who would like to receive credit will need to complete an online evaluation and enter the code that will be presented at the end of the webinar. Please remember that the code will only be available then and cannot be sent to anyone after the presentation. Now, please bear with me one moment as the lines are muted for the presentation. I'd like to remind our speakers to press #6 to unmute themselves after all lines have been muted.
The leader has muted your line. To unmute your line, press #6.
And now, I'd like to hand it over to Melissa Cumming from the Bureau of Infectious Disease and Laboratory Sciences and the Massachusetts Department of Public Health to introduce our speakers. Melissa?
Thank you, Nayara. On behalf of the Massachusetts Department of Public Health, I'd like to welcome everyone to today's webinar, and thank you so much for participating. Just to introduce our speakers, first we will hear from Shira Doron. Shira is a physician in the Division of Infectious Diseases at Tufts Medical Center, where she has been the physician lead of the Antimicrobial Stewardship Program since 2005 and also serves as the Associate Hospital Epidemiologist. Next, we'll be hearing from Shira Beaulac, who is the Pharmacist lead of the Antimicrobial Stewardship Program at Tufts Medical Center, as well as the Infectious Diseases Pharmacist for the institution. And third, we'll be hearing from Gabriela Andujar Vazquez, who is also a physician in the Division of Infectious Diseases at Tufts Medical Center. She is also a part of the medical center's antimicrobial stewardship team, where she has a special interest in rapid diagnostics and stewardship in the outpatient setting. And with that, I will turn things over to our speakers. Thank you.
Thank you. So today's talk is about antibiotic stewardship in long-term care. The time has come, and we're going to be specifically focusing today on the role of the consultant pharmacist in stewardship. Just a few brief words about the problem. We're going to frame the problem first by talking about antibiotic resistance and antibiotic use in nursing homes specifically. So there are 4.1 million Americans admitted to or residing in nursing homes in a given year. And this is data from the CDC. And it's estimated that up to 70% of nursing home residents receive an antibiotic during a year, and up to 75% of those antibiotics are prescribed incorrectly. So I did a quick back-of-the-envelope calculation using those numbers, and I found that the result is over 2 million inappropriate antibiotic prescriptions for nursing home patients in a year. And so that's why the CDC recommends the 7 core elements for antibiotic stewardship in nursing homes, which we'll talk about. Meanwhile, we have a lot of nursing home patients in this country, and the population keeps aging. So if you look at this graph, which has projected curves of elderly persons in the United States in tens
Excuse me, I don't mean to interrupt you, but is there supposed to be like something on the screen that goes with this? Because I'm not seeing anything.
There's a WebEx that you should.
There's a WebEx portion that you should have received an email confirmation along with the phone number. There's a link. QualityNet, do you see a link?
I don't. The only thing that I got, because this was something that I just found out about today, and I was like, I went in to my email that was forwarded to me, and they said, oh, click to register. So I tried to register. They said registration closed. So then I went to click the, go to the web event site, so I did that. And then I got a page that popped up that had the call-in number and access code. And then it's got some kind of...
On that page that you went to try to register, my email is on there. Can you please click on my name and email me directly so that the speaker can continue, and I will chat with you offline. My name is Myra Delaware. You can click on the contact Myra Delaware, and I'll speak with you offline, okay?
Okay.
Thank you.
So what you're looking at is the projected numbers of elderly persons in the United States over the next couple of decades. And as you can see, it's rising rapidly. And the other thing that's rising rapidly is antibiotic resistance. But these bugs are becoming harder and harder to treat. On the left, you see the percentages of isolates of Klebsiella pneumoniae, one of the common gram-negative organisms that's resistant to third-generation cephalosporins. So that represents our ESBLs, or extended spectrum beta-lactamase-producing organisms. On the right, you see the percentage of carbapenem-resistant Klebsiella pneumoniae, which is going up at an even faster rate. Specifically, though, in nursing homes, here's a graph showing the prevalence of colonization by multidrug-resistant gram-negative organisms in long-term care facility residents. And this is a meta-analysis of 12 studies looking at over 100 nursing homes. And overall, the estimate of multidrug-resistant gram-negatives are at a prevalence of 27%. And here you can see the specific organisms making up that total number of multidrug-resistant gram-negative bacteria. This is a smaller study, but kind of interesting in that it shows for 4 of the common multidrug-resistant organisms, in this case MRSA or methicillin-resistant Staph aureus, VRE or vancomycin-resistant Enterococcus, and then ceftazidime-resistant gram-negatives and Cipro-resistant gram-negatives down on the left and the right, respectively. The proportions of nursing home residents that have them divided out by whether they had them on admission to the nursing home or whether they acquired them in the nursing home. And so all of these residents were screened on admission and then periodically thereafter. And you can see that the vast majority of colonized residents in all of the categories are acquire their multidrug-resistant organisms after they've already been admitted to the nursing home. And so much of the prevalence of multidrug resistance in our nursing home population is preventable with appropriate infection control and antibiotic stewardship measures in the nursing homes. Most of these residents are not coming in already colonized. And when it comes to multidrug resistant bacteria, if you look at this list of potential risk factors for acquisition, and here we're talking about residents developing multidrug resistance while in your facility, interval antibiotic exposure. So antibiotics are really here the only risk factor that's statistically significant with an odds ratio of 5.5. And so if we do nothing else, we should be controlling our use of antibiotics to prevent multidrug resistance in the nursing homes. Why? Why do we care? Aren't there just going to be new antibiotics to deal with whatever new resistance mechanisms emerge? And the answer is no. Here is a graph showing number of new antibacterial drug approvals over time, which has been steadily declining, maybe a little bit of a hopeful situation there in 2010 to 2014, but overall what we can say is that that drug development pipeline for antibacterials has been running dry, and we need to think of new and different ways to prevent resistance, not rely on our antibiotics. Dr. Margaret Chan from the World Health Organization talks about a post-antibiotic era. analogous to the pre-antibiotic era, where there were no antibiotics. In a post-antibiotic era, this would essentially be an end to modern medicine as we know it, where things as common as strep throat or a child's scratched knee could once again kill. And that sounds dramatic, but that may actually be the future that we're facing. The CDC put together its first antibiotic resistance threat report in 2013, and it gave us some numerical estimates. So an estimated minimum number of illnesses and deaths caused by antibiotic resistance, over 2 million with 23,000 deaths. An estimated minimum number of C. diff infections, at least 250,000 illnesses and 14,000 deaths. The CDC categorized the various multidrug-resistant organisms into urgent, serious, and concerning threats. And you can see that a couple of our urgent threats are ones that we deal with in the nursing home setting: Clostridium difficile, carbapenem-resistant Enterobacteriaceae, and that in the serious category we see the ESBLs, the VRE, the MRSA. But it's not just resistance that we have to worry about when we use antibiotics, and particularly when we overuse antibiotics. It's also side effects. So antibiotics are actually responsible for almost 1 out of 5 emergency department visits for adverse drug events. And this is another infographic from the CDC Urgent Threat Report, that antibiotic stewardship in your facility will decrease antibiotic resistance and C. diff infections and lower your costs while increasing good patient outcomes. So it's a win-win for all that are involved. There's actually at University of Maryland somebody showing that antibiotic stewardship programs saved a total of $17 million over 8 years. And who wouldn't want that? So antibiotic stewardship improves patient care, shortens hospital stays, and benefits patients as well as hospitals or any facility. And I'm not saying that it's easy. Antibiotic stewardship is a balancing act. And so for the prescribers who are looking at the patient or nursing home resident in front of them and trying to decide what to do, there's this balancing act of, I need to give appropriate initial antibiotic while improving patient outcomes in healthcare, while avoiding the unnecessary antibiotics, the adverse patient outcomes, and the increased cost. And that is not an easy task. Hi, this is Shira Doron, and Shira's painted a pretty grim picture of the landscape of antibiotic resistance and how there's a daunting task ahead of us to improve antibiotic prescribing because the resistance will catch up with us. And it can be a little bit overwhelming. So I want to give you a few steps of, where to start. How can we begin to improve antibiotic prescribing? Antibiotic stewardship programs have been proven to be effective both in the hospital, but as well as outpatient settings and nursing homes. And we want to help arm you with some tools to have effective antibiotic stewardship programs. One of the easiest places to begin with an appropriate antibiotic prescription is to start in the right place. Remembering that whenever you treat a patient, the antibiotic needs to be in concordance with the disease state that the patient has, and thinking about what are the likely pathogens that could cause that disease state, and what are the likely antibiotics that can treat those pathogens. And all three of these kind of need to be in concert in order to effectively treat the patient. If you go a little bit too broad, you may have antibiotics that are effective for more than just those pathogens and maybe inappropriately broad, but you also want to make sure that you're not going so narrow that you don't adequately cover the things that you're trying to treat. So starting off with the appropriate antibiotic is a really great step one. An easy way to do that would be to use some evidence-based guidelines that can be resources to you in choosing the best empiric antimicrobial. The Infectious Diseases Society of America is a great website and has practice guidelines for almost every infection that you could encounter in the nursing home setting. And they're broken out by what type of organ system. There's even a couple bug-specific guidelines, like there's an MRSA and influenza guideline, and there are new pneumonia guidelines that are expected any day now. You may know that healthcare-associated pneumonia was historically part of the hospital-acquired and ventilator-acquired pneumonia guideline. In the most recent iteration, they kicked out healthcare-associated pneumonia, which includes nursing homes, and those will be incorporated in the new community-acquired pneumonia guidelines that should be out any day now. Aside from, within these guidelines, there's going to be multiple treatment options, and then, there's a little bit more onus to choose within those options, thinking about what is the most likely to be efficacious, what is going to be the safest for your patient population and for your specific patient. It's important to think about the cost and also the ease of administration. Within any given treatment guideline, there are going to be several antibiotic options that incorporate the fact that there is going to be varying resistance patterns across the country. If you can, and if you have access to an antibiogram for your facility, or if your facility is kind of part of a regional chain and you have access to an antibiogram, this can be really useful for helping you identify what resistance patterns look like in your area. The way you use an antibiogram is you look at the pathogen that you're trying to treat. Say, for instance, if you're trying to treat a urinary tract infection, you would look at E. coli, and then look at what is the likelihood that the antibiotic is going to be effective for that bug. So if you have an E. coli infection, ampicillin is only effective about 45% of the time, so probably not the best empiric agent. But likewise, you wouldn't want to necessarily start off with meropenem or ertapenem every single time. Even though they're 100% effective, that might be a little bit unnecessary or overkill, depending on your patient's clinical situation. If you do not have an antibiogram, which I acknowledge that a lot of facilities don't, the Massachusetts Department of Public Health has put together a statewide antibiogram that can help give you susceptibility guidance for the entire state. Here I have an example of the Pseudomonas susceptibilities, looking at all of the isolates across the state for 2017, and it shows you how there are certain organisms like certain antibiotics like Ace-Trianam and levofloxacin that are not as effective as some of the others like cefepime or amikacin. And then if you want to drill down a little bit further to your geographic region, the Department of Public Health has created this really novel and really cool tool called Resistance Open. And what that does is it incorporates antibiogram data and epidemiology and surveillance data to really hone in on your zip code. So you enter your zip code, and it'll look at the resistance rates geographically close to where you are. So you can get a really good sense of what resistance looks like in your area. Please note that I've put the links for both the statewide antibiogram and Resistance Open in these slides, and they'll be available to you within a few days after the webinar is done. It's important to remember that all of these generalities about antibiotic susceptibility for your region are really useful when you're selecting an empiric antibiotic or when you know what the identification of that bacteria is. But there's more to it than that. Once you take a culture from a patient, it gets sent off to the lab, it gets cultured out, they'll look at it and give you a gram stamp, and eventually they'll give you actual susceptibilities. They'll test out the different antibiotics, the different concentrations, and tell you what it's susceptible to and what it's not. And it's really, really important for improving patient care for multiple reasons to put the patient on definitive therapy, which means changing therapy to the narrowest effective therapy that is within the constraints of that patient's, whether it's safe and compatible with their other comorbidities, allergies, and whether it's IV or PO. Some of these antibiotics, you could have multiple antibiotic options for treating a single infection, but there's a lot of differences between the antibiotic options for those infections, one of them being cost. So here I have just a general list of, average wholesale price for a single day of varying treatments for, let's say, an invasive MRSA infection or an empiric UTI treatment. And you can see some things are as inexpensive as, $1 to $5 a day, whereas some treatments can cost several $100s per day. And it's useful to really have provide that pharmacist expertise to help inform prescribers about the cost implications of the antibiotics that they're prescribing. It's also important to remember that that IV is not necessarily better than oral, especially for antibiotics that have really good oral bioavailability. Fluoroquinolones, linezolid, metronidazole, clindamycin, Bactrim, and fluconazole all have phenomenal bioavailability. And there's very few instances in which an IV option is better than a PO option. In the cases where patients on IV were switched to oral antibiotics, it's associated with a shorter length of stay, at least in the hospital. It's associated with overall decreased cost of care, and it decreases the risk of line-related complications like CLABSI. There's also additional benefits for our heart failure patients or our hypertension patients that may be fluid or sodium restricted. You might not realize, but some of these IV antibiotics have a really heavy sodium or potassium load. Metronidazole, 500 milligrams 3 times a day, which is a pretty standard dose, if it's given IV, has almost a gram of sodium per day, which is a lot, especially for our restricted patients. Also, certain drugs undergo enterohepatic cycling. So something like metronidazole, which gets absorbed into the systemic circulation, excreted into the bile gets excreted back into the GI tract, and you can reabsorb some of that metronidazole, getting a second peak effect. And that way you're getting potentially even better bioavailability out of the oral formulation than the IV. And lastly, in terms of patient satisfaction, it's in general, surveys show that patients are much more satisfied with their care when they receive oral treatments as opposed to IV treatments. So it really just improves care overall. So with that, I'm going to cast it over to Gabriela, who is going to talk about some common scenarios in which antibiotics are overused.
Hi, so Gabriela, and I'm going to present common clinical scenarios maybe we should think about improving. So we have a 75-year-old resident vascular patient with chronic leg ulcers who was transferred to your facility, and it was noted on admission that she had increased serous drainage from her wounds. So this was swabbed superficially for wound culture that eventually grew MRSA. So the patient was started on doxycycline for 14 days, despite having no systemic symptoms and reporting that the wounds were stable. So this is a classic example of what is different between infection and colonization. Colonization means that bacteria are present, but it's not necessarily causing disease as opposed to infection, and that the bacteria that patients are colonized with are often transmissible through hands, and often patients get infected with the same bacteria that they're colonized with. So in our case scenario, our patient's wounds are colonized with MRSA, but the fact that we had a culture that grew bacteria from the wound does not mean that she's infected, since she was not showing any clinical signs or symptoms of an acute lower extremity ulcer infection. So probably doxycycline could have been avoided in this case. So our next case is a 85-year-old resident who has Alzheimer's and is reported by family and staff of being off. Resident has no complaints, but a urinalysis is sent, and this had white blood cells, and the urine culture grew more than 100,000 ESBL E. coli. Family member demands an antibiotic started, so a line is placed, and she started on erlopenem for 7 days. I'm sure we all have heard this type of scenario at some point in our career, and there's no doubt that this case can be challenging to navigate, but there are specific guidelines put out by the Infectious Disease Society of America and other entities that give recommendations on asymptomatic bacteriuria. In our case, classifies as asymptomatic since changes in mental status alone are not clinical signs for the diagnosis of UTI. Based on published evidence, the guidelines only recommend treating asymptomatic bacteriuria in pregnant women and patients that are undergoing an urological procedure. Furthermore, they highlight that the fact that asymptomatic bacteriuria or pyuria is highly prevalent in women, and approximately 32% of young women, 30 to 70% of pregnant women, 70% of diabetic women, and 90% of elderly institutional patients, which is our population that we're mainly speaking about, 90% of hemodialysis patients, 30 to 75% of bacteriuria patients with short-term catheters in place, and 50 to 100% of individuals in long-term care with indwelling catheters. So this highlights the point that just because you send urine and bacteria grows, it does not mean that your patient has a UTI and that they need an antibiotic. Urinary symptoms have to be present in order to reach UTI diagnosis, and changing mental status does not equal asymptomatic UTI. Now, I am aware that many of the challenges related to this topic could be family members insisting on certain antibiotics, or the patient is not the best historian, etc. But this is an opportunity first to counsel families on the risk of giving unnecessary antibiotics to their loved ones. And in our scenario, our patient already had an MDRO and an SDL, driven by probably previous use of inadequate course of antibiotics, now leaving her with no oral options for when she truly becomes infected and sick, and not to mention the other side effects and adverse events that can happen with insertion of line for antibiotic use, antibiotic-associated diarrhea, etc. So I think if we talk to families and patients honestly about the risk and consequence of taking unnecessary antibiotics and explain to them a reasonable plan of action for the change in their family members' behavior, I'm sure they would listen and be on board. And we know this takes time to achieve, but slowly you can start creating cultural change not only with your staff, but also families and patients that are just as important. So in our next case, there's an 80-year-old man with upper respiratory tract symptoms for 2 days, was recently treated for pneumonia in the hospital. The sputum culture was sent, and it was not a very impressive gram stain, a culture that grew 2+ Candida albicans and 2+ normal respiratory flora, which is suspicious for oral flora. Flu test was negative, check was unchanged, but he was given levofloxacin for 7 days. So this case is a good example of treatment of what is most likely a viral upper respiratory tract infection. And note that the granddaughter was also sick and with a cold, so probably gave grandpa the cold. And note that he had pneumonia recently, so his chest x-ray might not have been perfectly normal. It takes weeks for it to resolve because he was in the hospital recently for this. I also want to highlight that the sputum culture result is very common reflection of respiratory colonization, since Candida is often a colonizer, and the fact that in the gram stain there are no squames and no polys with a culture that grew normal respiratory flora makes it very suspicious for either a bad sample or with oral contamination. Another thing to know is the chest x-ray did not show an infiltrate, probably due to previous recent pneumonia. And we know that radiographic improvement lags after treatment. So taking all this into consideration, probably this patient did not need levofloxacin since he did not have a bacterial infection at that time. Finally, we have the last case, which is a 65-year-old resident who had 1 loose stool overnight, and this was sent for C. diff. He had been positive a month ago at the hospital and was treated. Next morning, his bowel movements were completely normal, but they sent the overnight stool for C. diff, and it came back positive by PCR. So he received a course of 14 days of oral vancomycin. So this case hits on some key concepts around C. diff diarrhea, infection control, antibiotic, and diagnostic stewardship. In terms of C. diff diarrhea, we know that C. diff PCR can represent dead organisms since it's identifying DNA, and that the fact that it is positive does not mean acute infection, but rather colonization. If patients are asymptomatic, but like in our case, he had recent history of C. diff, which means that it's not unexpected that his C. diff was still positive by PCR because he had C. diff infection in the past. But another important point is that he had 1 loose stool only 1. And stool for C. diff should not be sent for just 1 loose stool, and it should be only considered to be sent in patients with 3 loose stools in 24 hours or more. And another point that I want to make is an infection control surveillance key point, which is that C. diff test will count as a facility-acquired CDI since he was positive after 1 week of being admitted at the facility, and his stool was C. diff positive at the hospital more than 14 days prior to admission to the facility. So in this case, the patient should have not been tested for C. diff, and even less so started on another course of C. diff, since we know that this will increase his risk for future C. diff, CDI. So lessons learned in all these 4 cases is we have an understanding of the difference between colonization and infection. We know wounds can grow different organisms from culture. That doesn't really mean infection. And that most of the time, even with increased drainage, only local wound care is all they need. we should make a thorough evaluation for altered mental status in patients with dementia and avoid culturing if no clinical signs of symptoms. And we should try to engage patients and families into the conversation of being smart about antibiotic use. Remember, viruses are the most common cause of upper respiratory tract infections, and symptoms can last for weeks. Sputum cultures can often be contaminated with oral flora, and a positive C. diff PCR only may have colonization rather than infection. And giving antibiotics for CDI can increase the risk for CDI. So now I'll pass the mic to Shira, who will talk more specifically of the role of the pharmacist in the long-term care facility, federal requirements for antibiotic stewardship.
Thank you. So I'm sure that the pharmacists on the line are shuddering when they hear the word mega rule. But I just want to remind you what are the exact requirements for facilities and for pharmacists regarding antibiotic stewardship in nursing homes and long-term care facilities. So the exact verbiage is that there's a requirement for the facility to perform a facility-specific assessment of their resident population and facility, and then also that there has to be an antibiotic stewardship program that includes antibiotic use protocols as well as a system for monitoring antibiotic use. And that's the area that especially requires ongoing pharmacist intervention. So, as I mentioned, there needs to be antibiotic use protocols as well as stewardship program protocols. These protocols need to be reviewed annually and incorporated somehow with the infection control program. There needs to be some sort of a system for monitoring antibiotic use, and there could be multiple points at which that evaluation happens. It could be when a resident is new, or when they're transferred from a hospital or other facility. It could be during monthly review. It could be with every new antibiotic start. So there's a lot of opportunities of when that system could go into play, but that just needs to be clearly delineated in your policies and procedures. That what your findings are from those reviews needs to be fed back into the infection control program and fed back to prescribers about the appropriateness of their prescribing, as well as if there should be at least one protocol around antibiotic prescribing, and prescribers should get feedback about the compliance with that protocol. That assessment of whether or not the antibiotic is appropriate and communication about that antibiotic course is supposed to occur by a pharmacist, and it's supposed to occur at least monthly per the regulations. So as I mentioned, there's the overall stewardship policy that needs to be written, and that needs to outline membership, and the mega rule requires that there at least be one clinician, whether it be the medical director or their designee. There needs to be at least one infection preventionist on this committee, and there needs to be at least one consultant pharmacist. They list a couple of other optional members, but those are the three core roles that need to be filled in the Antibiotic Stewardship Committee and need to be outlined within the policy. And then some other key pieces of the antibiotic stewardship policy are outlining exactly what is going to happen, who is going to do what, and what time and effort they have to carry out those activities, and outlining the roles and responsibilities. So the expectations of the consultant pharmacists are to support the assessment of the appropriateness around these antibiotic courses, doing the monitoring, and communicating about the antibiotic use as part of the routine medication regimen review. The medical director or the designated prescriber is supposed to be accountable for that information and really be a welcoming ear to that information that the consultant pharmacist is providing. The medical director is supposed to help with policy development and serve as an educational resource to other prescribers. Another piece of the policy is to create some sort of infrastructure or system for ongoing antibiotic review. These policies, both the antibiotic treatment policy as well as the stewardship policy, need to be reviewed and updated at least annually. In terms of the responsibilities of the subcommittee, I'm kind of harping, but just you really need to have some sort of protocols around how to use antibiotic use how to use antibiotics, and you need to keep an eye on it. Don't just set it and forget it. It's recommended to have an annual antibiogram, and as I mentioned earlier, there's some state resources that can help you if you don't have a facility-specific one. The medical director is supposed to serve as that kind of primary point of contact and help with not only developing these guidelines, but also, facilitate education of other prescribers and also the conduit for that individual feedback towards other prescribers. And lastly, the consultant pharmacist, in addition to doing their at least monthly medication reviews, also consider not only ongoing antibiotic courses, but also looking at the appropriateness of completed antibiotic courses, and then make any recommendations as appropriate to the stewardship committee based on their findings. So that's a lot around just the requirements by law. But I know that I've spoken to a lot of pharmacists that really want to do this and are finding a lot of barriers. And I wanted to provide you a few opportunities and resources to identify some resources that you can use to be a more engaged stewardship pharmacist in your long-term care facility. So there's two programs or certifications that are available to pharmacists, specifically in antibiotic stewardship. One of them is provided jointly by SIDP, which is the Society of Infectious Diseases Pharmacists, as well as ASCP, the American Society of Consultant Pharmacists. So they've joined forces to create this certification for pharmacists to be an antibiotic stewardship certified pharmacist. It is comprised of of 3 phases. The first part is a self-study online learning program. It takes about 3 months to complete phase 1. It comes with 17 hours of ACPE accredited continuing education credits. Once you've completed those 17 hours, you can then move on to the live webinars, which are completed over approximately 5 months, and that takes about 4 to 8.5 hours, depending on which elective modules you choose. And lastly, once you've completed all of your didactic training, there's a skills component in your practice setting, which is comprised of phase 3, and that's about 4 months. It's expected to take about 10 hours, and it requires for you to do some sort of implementation of some quality improvement project, but it also helps you comply with the mega rule requirements. The entire program needs to be completed within 14 months of when you register, so although there's approximations of about how long it will take, you do need to show some ongoing progress, and it costs $850 to be certified. Another antibiotic stewardship certificate available to pharmacists is provided through MAD-ID, which is Making a Difference in Infectious Diseases. Now, this stewardship certification is not specific to long-term care like the SIDP, ASCP one is. This is just overall antibiotic stewardship, and it comes in 2 different levels, either the basic or advanced program. In the basic program, there's 3 multi-lesson modules, as well as a practical component, just like the other certification. The first 2 modules cover basics, and then the 3rd module has electives. Throughout the modules, you end up getting 16 hours of CE credit. The advanced program is a live program, so you actually go to the MAD-ID annual meeting. It provides 16 hours of continuing education over 2 days, and the cost of registration is $500 for the basic program, which is the one that you do remotely, $225 for the advanced registration or advanced program, but that is also in conjunction with registration for the annual meeting. You can't just show up for the stewardship piece. So ideally, your facility or your parent company, the pharmacy that you work for, is going to support you in getting some of these additional certifications. But sometimes we just don't have the money and resources to do all these extra certifications. So I want to give you some other resources that you can just do at home, do your homework, and really be knowledgeable about how to wisely use antibiotics to be an informed consultant, to
to really help your facility use antibiotics better. So I already mentioned earlier in these slides, and can only emphasize these IDSA guidelines are incredibly useful. And recognizing what the guidelines recommend and how those recommendations compare to your patients is really important in serving as a credible and useful resource to the prescribers at your facilities. Additionally, there's tertiary resources like UpToDate and Lexicon that provide antibiotic dosing recommendations, and UpToDate has a lot of articles about various disease states, including infections and also various others that are really they're kept up to date, as the name suggests, but they're also they're vetted, they're evidence-based, they're peer-reviewed, and non-biased, and a great way to kind of brush up on any given topic. And lastly, if you're a member of any of the national societies, they often provide a lot of free resources as well. The American Geriatric Society, the Infectious Disease Society of America, and American Society of Consultant Pharmacists all have free resources provided to their members to help with prudent and judicious antibiotic selection. Now, in terms of being able to be an effective steward, part of it is knowing how to do that, knowing all the background about how to wisely use antibiotics. And the second piece of that is providing meaningful feedback to the facilities that you serve. So one of the ways that pharmacists can be especially useful to the facilities that they serve is to help feedback information about how they are currently using antibiotics. Now, many consultant pharmacists I know provide reports back to their facilities about how many prescriptions were written in any given period of time, or can provide information about, how many starts there were, which antibiotics were started, things like that. But if you can also provide this information either to the facility or to the state itself, Massachusetts is collecting antibiotic start data for the entire state for all long-term care facilities that are licensed here, and we're able to use that information to benchmark yourself against other nursing homes. So that way, not only are you getting fed back the quantity of antibiotics that you're using, but it also helps give you a little bit of a sense of the quality to identify if you're an outlier in any way, prescribing far more or potentially even far less antibiotics than other nursing homes in the state. Many facilities have been submitting, and we've been trending this over 2018. And with our webinars that we've been giving, we were hoping to see a decrease in the number of antibiotic starts per 1,000 patient days over the course of 2018, but if anything, we've actually seen an increase. Part of this is a little bit to be expected in the fall. We see higher numbers of antibiotic prescriptions due to the seasonality of infections. But also, one of the things that may lead to a greater number of antibiotic starts is increased use of de-escalation. So if an antibiotic is started empirically, and then after 3 days, cultures come back and their antibiotic is de-escalated, technically that counts as another antibiotic start, but realistically, in the grand scheme of things, that's actually better for patients and better for all. So it may inflate your numbers, but really is the best thing to do for patient care. Drilling down specifically into UTI and respiratory antibiotics, we see really high rates of fluoroquinolone use, reasonably high rates of macrolides, and again, that kind of follows the seasonality as we would expect. Bactrim and nitrofurantoin have been kind of a little bit more stable throughout the time period that we looked at. And looking at more broad-spectrum antibiotics like third and fourth generation cephalosporins, carbapenems, and aminoglycosides, the one thing that we do really see is really high rates of third-generation cephalosporin use, and that has been increasing over time as well. So these are all opportunities for us to intervene, improve antibiotic prescribing, and then along those lines, use your facility-specific report benchmarked against other nursing homes to see if you're part of the problem and if there's opportunities right at your doorstep to help improve antibiotic prescribing, both at your facility and across the state. Now, nobody prescribes antibiotics intentionally inappropriately. Everyone that goes into healthcare, everyone that goes into medicine does it for the right reasons, because they want to help people, and especially in long-term care where, let's be honest, sometimes it can be a little bit thankless and it can be a really hard job. Nobody wants to do this. Nobody's trying to do the bad thing. Everyone's trying to improve the care of the patients that they're taking care of. And still, that's leading to potential imperfect care with antibiotic overuse. So there's a lot of drivers that can lead to antibiotic overuse, because we all want the best for our patients, but there's other things that can kind of get in the way. So one of the big things that we worry about is uncertainty avoidance. So you never really know what's going to happen to the patient. Especially our elderly patients can get sick at the drop of a hat. They can seem okay one day and then get dramatically sicker the next day. But really thinking about, what is the reality that's the most likely thing going on with your patient at any given time is an important thing to keep in mind, as opposed to trying to do everything for every patient every single time. That will put us in the position that we're in now with overuse of antibiotics, as many other resources as well. It's also important to have appropriate perceived expectations, both from the patient and their family, as well as from other clinicians. This includes expectations, rebaselining from the patient and their family that the watch and wait strategy that you may be employing is actually a legitimate strategy and not, kind of ignoring their signs and symptoms. It's not a scapegoat approach. If anything, it's kind of the more cautious thing to do is to watch and wait, rather than blindly start antibiotics and not really know what's going on with the patient. Additionally, with other clinicians, we not only need to think about, normalizing expectations from the prescribers, the pharmacists, and the nurses, but also from peer-to-peer comparison as routine feedback gets initiated, making sure that there's similar expectations about what should and should not warrant treatment across all patients. Another thing that really drives antibiotic overuse is that there's often a big distance from the poor outcomes. The negative consequences like C. diff or development of resistance often doesn't happen until days to weeks, sometimes even months after that antibiotic course, and without it having directly in your face at the time of decision making, it can sometimes be easy to distance mentally that those two things really are very closely linked. And lastly, we do live in a very professional society, and prescribing etiquette really does support a culture of hierarchy and non-interference, where nobody wants to step in and say, hey, Dr. So-and-so, you shouldn't be doing that. We're respectful and cordial to each other, but I'm going to give you a few strategies to help improve antibiotic prescribing with your prescribers, but in a way that's professional and effective. So one of the strategies that I recommend using for our holder prescribers is really to cater to what they want to hear and how they need to hear it. So that includes communicating in a way that they prefer, as well as using some motivational interviewing techniques that I'll get at in a minute. But it really helps to kind of make it personal, tug at their heartstrings, and underscore how their antibiotics course this time affects the greater good, but also, if they have a patient that they've treated that had a connection to, make sure that they recognize the role that antibiotics held in that person's care. I also recommend, calling reinforcement and using leadership to your benefit, but also only pull that card if you're certain that you have them on your side. And I also acknowledge that in some facilities, leadership is part of the problem. And lastly, if needed, steward around them. Do other things that can help them make more informed decisions when they're prescribing, as opposed to doing the after-the-fact reprimand. So if that means having your microbiology or laboratories displayed only sent in certain circumstances, or only displayed in a certain way that helps them make more informed decisions about prescribing as opposed to after they've already treated an asymptomatic bacteria telling them that that course was inappropriate. Additionally, I highly recommend that consultant pharmacists work very closely with nurses, especially in the nursing home setting. They really, run the show, and they're really the ones that are there at the front line every single day and know those patients better than anyone. So really, work with the nurses to kind of help them remind the providers. Mrs. Jones did really well eating her breakfast this morning. Do you think that her IV antibiotics could be switched to pills? Or ask the nurse to, if they're asked to collect a urine specimen in a patient that will be colonized because they're fully been in for 3 weeks, have the nurse at that point intervene as opposed to, again, kind of reprimanding on the back end after the culture's been sent, after the patient's been treated, and then when you realize that it was potentially unnecessary. So I also mentioned a little bit about using techniques of motivational interviewing to really get through to the prescribers. When you have these difficult conversations, you want to come at them with from a place of empathy and respect. So making sure that you're demonstrating the gravity of the situation, that you respect what they're doing, and that you have the same mutual goals, which is to improve patient care, and you recognize that it's not an easy call to make whether or not a person needs antibiotics or whether that was the right antibiotic. You want to develop discrepancy, which means make it clear that although it was a really tough call, the ideal state would have been to use no antibiotics. Or the ideal state would be, now that we know the culture's susceptibilities, potentially we didn't need a broad spectrum antibiotic, things like that. Make it clear that what they did was not the ideal situation. Avoid direct confrontation, because obviously we know that getting into fights is not going to help anyone. It's not going to help you in that case, and it's also going to impact your ability to be effective going forward. Make sure you adapt accordingly and really modify how you approach that prescriber based on how they react to you. So even if it's something as small as modifying your body language or your positioning, the way you're standing, just to accommodate that resistance rather than directly opposing. And lastly, work together and serve as an advocate for the patient to really come up with a plan that suits both your goal as the antibiotic steward as well as the prescriber's goals, and making sure, again, going back to that mutual goal of improving patient care, identify how both of you together can work on that. And then these are all things that you can do in the moment to improve antibiotic prescribing at a face-to-face conversation, but there's also other little nudges that you can do to improve antibiotic prescribing kind of from a holistic perspective. So this was a study that was done in primary care practices, but a lot of the theories apply to long-term care as well. They looked at 47 different primary care practices in Boston and LA, and there were 248 clinicians that were randomized to receive 0, 1, 2, or 3 different interventions that were meant to improve prescribing around upper respiratory tract infections. The 3 interventions that they did were what they called accountable justification, which meant that the physician had to document why they were writing antibiotics for an indication for which antibiotics are not generally indicated. They also had an intervention of peer comparison, where they provided a monthly email to inform providers that they weren't a top provider in antibiotic prescribing. So that way, and obviously conversely, they also informed prescribers that were top performers to help motivate them to really strive to be their best. And lastly, they created some suggested alternatives that included over-the-counter and non-antibiotic treatments for symptom management. Now, all 3 of these interventions, either by themselves or in conjunction with each other, all had some impact on antibiotic prescribing. And notice that the changes are not hugely dramatic. A difference of maybe 5 or so adjusted antibiotic prescriber days per month, but it's a small intervention, but it's durable, it's sustainable, and can really help improve prescribing overall.
another study that looked at antibiotic measures, I'll speak quickly because we're running out of time, but essentially another intervention in the UK that provided advice on self-care, advocated for the delayed prescription strategy in which you do a little bit of watch and wait, and then also doing some patient and family-specific education with posters and attestations that the prescriber is dedicated to antibiotic stewardship. All of those had small but significant impacts on antibiotic prescribing. So with that, I will open for questions, and I'm also going to go back to some of the questions that were in the chat box. So here, okay. So the slides for print, the link is provided. It'll be posted in a few days. In terms of meeting criteria for signs and symptoms for antibiotic use in the elderly, we recognize that elderly rarely spike a fever and are on a scheduled Tylenol, which may mask a fever, and it may be unclear if there's pain or urgency. But the big thing to recognize is that if there's something that's very noteworthy in terms of difference from their baseline, acknowledging, and there could be other symptoms, looking for something like a leukocytosis that could also be useful for diagnosis of a urinary tract infection in someone who doesn't verbalize symptoms. The other point that I didn't go into depth in the case that I presented earlier, but also, I mean, most of the time, like, it's just reflex. The main issue is also this reflex of something urine just from a couple of hours of change in behavior. Reevaluating medications, reevaluating if there was any change in diet, anything that maybe changed in even the room or something like that, that will maybe have changed that behavior in that day, but reflexing to just send the urine when maybe it's been a couple of hours and being a little off, is also to, a watchful wait, which Shira had mentioned also, to try to figure out if it's really unnecessary to send a urine, but also taking into consideration other things that might change the behavior on the elderly. Yeah, and then so next to answer Kelsey's question about a resource for the most commonly used antibiotics and the recommended durations and dosing, that resource I would highly recommend looking into the Infectious Diseases Society of America guidelines. They have guidelines for each of the common conditions. Some of them are going to be more hospital-focused that are not going to be as relevant to you, but some of them are going to be incredibly relevant to you. Specifically the urinary tract infection guidelines, the asymptomatic bacterial guidelines, the C. diff guidelines, the ones that are most relevant to your day-to-day practice. Next, in terms of training for nurses, so admittedly this webinar was intended to really focus on the role of the consultant pharmacist, but there is APIC certification for nurses to become certified infection preventionists. And then lastly, the response to prescribers when they think the risk of sepsis is greater than not prescribing due to lack of symptoms. I'm not certain that I follow. No, I think what they're saying is, particularly when it comes to UTI or question mark pneumonia, the reason that prescribers use antibiotics, even when they're not sure if there's an infection, is because the downside of failing to treat a true infection could be sepsis. And nobody wants to take there's sort of this feeling like I don't even want to take even the slightest chance that I'm not treating an infection because what if the patient becomes septic? And sort of there's this old school kind of feeling that antibiotics are the safe way to go. The least risky approach to a patient with a possible infection is to be on the safe side and use antibiotics. And we really need to shift that mindset because certainly nobody wants any patients to get sick and septic, but we shouldn't think of antibiotics as the safe way to go or what you do when you want to be on the safer side, because 100% of the time when you give antibiotics, you're causing harm. It may not be very measurable harm, but you are impacting
tremendously that patient's microbiome, their normal intestinal and other flora. And that has long-term consequences. Increasingly, studies are showing that creates not only resistance, not only risk for C. diff, not only antibiotic-associated diarrhea, but all kinds of changes that affect immune function and metabolic function and nutritional changes. So I think the important thing is to have a very critical approach every time antibiotics are used. There are some long-held beliefs that have really not stood the test of time and stood the test of research. The idea that mental status changes are due to UTI is really not, even that kind of basic concept that's been around for so long is really not proving to be true. And if you think about bacteria in the bladder and how they would create that mental status change, it doesn't even really make that much sense. And now that we are aware that 50 to 80% of female nursing home patients have bacteria in their bladder at any given moment, and then how common changes in mental status are, we realize how we might have made that mistake for so many years in a row, but we have to change our mindset on that. And with that, we'll pass it back to Nayara.
Alrighty. Thank you, Kira, Shira, and Gabriela for a great presentation, and thank you, everyone, for your great questions. Let's see here. For those pharmacists who will be claiming continuing education credit, the ACPE code is Consultant Pharmacist. And just a reminder, we cannot email this code after the webinar, so again, that code is Consultant Pharmacist. Upon closing out of this window, you'll be directed to an evaluation of today's presentation, which is where you'll enter the ACPE code. Filling out the evaluation is part of the requirement for obtaining the credit. As you can see from this slide, the learning opportunities continue. On February 26th, we will be having our prescriber-focused webinar, and on March 12th, we will have our next session of this advanced series. We'd like to encourage you to reach out to us if you have any questions, feedback, or concerns. On this slide is the contact information for Sarah Dudley from the New England QIN-QIO and Melissa Cummings from MDPH. Don't be shy. We'd love to hear from you. And last but not least, we know your time is very valuable, so we'd like to thank you all for joining us for today's presentation. We thank our speakers again, and until next time, have a great day, everyone.